You are with Cape Talk.
Views and News with Clarence Ford.
Welcome back, 9:35. It is Views and News, Strudel 12, with me, Clarence. And that big appointment now with our naked scientist. He returns every Friday just after 9:30. And he answers our questions. Consultant virologist at Addenbrooke's Hospital in Cambridge, Dr. Chris Smith, the naked scientist, on air now via Zoom from London. Welcome, Chris. Great to have you back.
Morning, Clarence. How are you doing?
I'm good. It's World Diabetes Day. We've been talking the topic, and there's a question or two for you.
My goodness, I didn't even know it was World Diabetes Day. There's a World Day for everything these days, isn't there? The one that's really
There is.
pertinent to me, given my microbiology job, starts next week. And that's because it's World Antibiotic Awareness Week. So you see, that's more important. That has a week. I mean, diabetes only affects about half the world population. No, I'm kidding, of course. Diabetes is a very, very important subject and a very, very important issue and a growing problem because it's one of the most costly health problems because so many things lie downstream of diabetes and it's one of the preventable things. If you have type 2 diabetes, which is associated with obesity, because we can prevent that, we can potentially prevent a lot of cases of type 2 diabetes and therefore all of the enormous consequences and health spend that comes downstream. So it's a major health priority, not just for South Africa or the UK, but for the whole world.
Yeah, and I think Brenda, let's put Brenda's question to you. She wants to know unequivocally if type 1 diabetes is not curable. And I guess there's a short answer and a long answer.
Brenda, type 1 diabetes is different to type 2. Type 1 diabetes is where a person has absolutely no insulin in their body at all. A type 2 diabetic actually has very high levels of insulin, at least to start with, and the problem is not that the insulin isn't there, it's that the insulin isn't working properly. So in a type 1 diabetes patient, why do they have no insulin? The reason is usually because the immune system has, for some reason, and usually in early teens or late childhood, turned on your own insulin-producing cells and killed them off. And this can be in the wake of a viral infection. There's a seasonality to type 1 diabetes, which means it's more common at certain times of the year, and at certain times of the year, certain infections are more common. And there are certain associations with certain viral infections that we think induce a state of molecular mimicry. So when the body fights off the virus, it ends up making an immune response that sometimes mistakes the diabetes-related insulin-producing cells with virally infected cells, so as well as clearing the virus, it then goes after your own tissue. The problem is, once you have that immune response that's there killing off anything that looks like an insulin-producing cell, if the body tried to produce new ones, they might become subject to the same immune onslaught. So one way to treat the problem might be to put the cells back, but make them look different, effectively disguise them. So researchers are doing this in a number of different ways. They're using stem cells to engineer new insulin-producing cells, but then put them beyond the reach of the immune system. One way, put markers on them that make them look different because the immune system's only going after certain cells in the body, not all the cells in the body. So if you disguise them as a different kind of cell, that could work. The other way is to sequester the cells in a sort of matrix that can let goodies, nutrients and chemicals in and out, but doesn't let immune cells in. And so sequestered implants that have the insulin-producing cells in them might be another way around this. And the other way of doing it is to just use technology. And scientists now have got the most amazing artificial pancreas devices, and including some in the UK who've got these chemicals that can basically release insulin in response to blood sugar. So they actually do it chemically. The other way of doing it is electronically. They've got devices that squirt a certain amount of insulin in response to blood sugar. And so we're certainly making huge strides. This just didn't exist 2 decades ago, and now we're in a position where it does. So I would watch this space, and certainly you never say never in medicine. So I think there's certainly a high likelihood this will be, and you use the C word very cautiously, cured in the future.
It does look like that. They say the pace of research is faster than ever, and a functional cure, they say, seemed closer than it has ever been. So Brenda Cook diagnosed type 1 at age 50. That's the status on, hopefully, that cure that they are enthusing about. Now, a question about a black eye. What is the cause of a black eye, And is that the same what some boxers get after fights? Maybe just leave it to heal by itself. I don't know if Keith is suffering one at this moment in time.
I hope not.
What
My
exactly
daughter
caused it?
has got black eyes at the moment, 2 black eyes, because she got hit with a hockey ball in the face, right on the bridge of her nose last weekend while she was playing for her university. And not quite as black as the last time she got hit by a hockey ball, but she has 2 symmetrical black eyes. So why is that? Well, the injury has happened to her nose in that case, and it's caused bruising. Where does the bruise go? Well, if you bruise any part of your body, that is where you've injured blood vessels. The blood vessels have leaked, blood has come out into the tissue, and when blood becomes deoxygenated and begins to break down, it goes through a series of colour changes. And hemoglobin, the red pigment in blood, as you deoxygenate it, which is what will happen when it gets out of a blood vessel and into the tissue, it goes a bluer colour. So the bruise is partly deoxygenated hemoglobin. Then the bruise evolves into a green and yellow and browny colours, and this is because as hemoglobin is broken down by your immune system that comes in to clear up the damage, it breaks up the molecule hemoglobin into a series of subsequent derivatives, which include a substance called biliverdin, which is green, and bilirubin, which is browny yellow. And these spread out slowly in the skin, giving the sequence of colour changes you see as a bruise matures. Now, in the case of black eyes, if you think about the anatomy of your eyes, when you injure your nose, you're not injuring the eye, but the eyes go black. Or if you punch yourself or get punched in the face near the eye, you're not injuring the eye, you're injuring the skin and the tissue near the eye. But the eye socket is a depression. It's a bit like if you have a hole in the ground and you pour water on the ground, it runs into the hole. Well, your eye socket is a depression in your face, and the drainage and the blood vessels there that take the tissue fluid away work in a certain way assisted by gravity. So what tends to happen is that the blood that comes out of broken blood vessels and then the breakdown products of the blood, the biliverdin, the bilirubin, all the coloured products, they just flow downhill through your anatomy into your eye socket, and they collect in the tissues, usually below the eye, producing those colour changes in the skin, which is very thin there, because for various reasons you want your eye to be able to move freely. You don't want big thick skin stopping your eye moving around, and as a result you can see those colours very clearly through the skin. So it's a gravity effect and a thin skin effect that makes those colours very obvious in that part of the body.
Gregory's question reads, please ask the Naked Scientist the following question. What is the best method of stopping severe bleeding and how to do it?
Gregory, it really comes down to the fact that, number one thing, don't get severe bleeding in the first place, because it's a major reason why people die. People, if you injure a major blood vessel, you can bleed out and lose most of your circulating volume in seconds to minutes. If you injure a big artery, blood is being forced out by your heart at really high pressure, and you can lose litres in next to no time. Once you've lost more than about 20% of your circulating volume, unless you're very promptly helped, then that's a lethal hemorrhage. So you've got to be really, really careful. The number one thing any medical practitioner will do when they see bleeding is pressure. So you get something, whether it's a bit of your shirt or whatever, and you put it round your hand and you press that onto the thing that's bleeding as hard as you possibly can. And while you're doing that, you're calling somebody, get me some help. Because the likelihood is, if you've got major bleeds going on at very high pressure, the minute you take that pressure of your hand off of the wound, it's going to open up and start bleeding again. So you need a surgeon. You need someone who can repair blood vessels, and you need them quick. So number one thing, put pressure on. And if it's just you on your own, put pressure on there and don't take the pressure off. Number two, get somebody to get some help for you quickly. And then what they'll do when they come along with hopefully surgical skills is repair the hole in the blood vessel, while another team of people are putting the blood pressure back up by putting the fluid that you've lost in, usually through a vein somewhere else in the body. Now, if it's a trivial injury, on the other hand, again, it's the same thing. You apply pressure. What's the pressure doing? Number one, it's squeezing blood vessels closed, because if a blood vessel is squeezed almost shut, the amount of blood that can flow through the hole is much smaller, so you'll lose less blood. But also, at any site of injury in the body, the injured tissue activates small elements in the blood, which are called platelets. These are bits of cells. They're made in the bone marrow by big cells that then fragment and give off bits, these platelets. And platelets are very sensitive to low oxygen, but also the presence of tissue that they don't normally see inside a blood vessel, specifically connective tissues and collagen. And the minute the platelet sees this abnormal surface, it activates. And that means it goes from a nice smooth contour to this jagged, star-shaped object that jams into holes. So that takes time, but if you've got pressure on, you're helping the platelet to then stick into the hole, plug the hole, and then they activate the clotting cascade that makes a thrombus on top of the platelets, and that plugs the hole. So it really comes down to severity. If it's really, really bad, pressure, call for help quick. If it's trivial, put the pressure on, put the body part up in the air above your heart to get the pressure down, and hopefully with pressure and patience, then it'll stop bleeding.
Question in from Andre. Many African Americans suffer from sickle cell anemia. Is it only a deficiency amongst Africans from tropical malaria-ridden regions of Africa, and can it be overcome?
Sickle cell anemia is quite well understood these days. It's an inherited genetic condition, and it has a carrier state and a disease state. Let me explain. When you carry this mutation, because you have 2 copies of each of your chromosomes, if you've only got it on one chromosome because only one of your parents had it and gave it to you, then that gene will be affected, but the other gene won't. So you make a mixture of hemoglobin, which is the red stuff that blood uses to carry oxygen. You'll have a mixture of the abnormal hemoglobin and the healthy hemoglobin. And this is consistent with healthy life, but occasionally it can get worse if you have certain reasons why a person may develop a more severe problem. But usually people are perfectly okay with that, and it confers the added advantage that people with sickle cell anemia trait, which is what that is, are very hard to infect with malaria. So unsurprisingly, if you have a human population where this gene can get changed and you can get this condition, if you live in a part of the world where malaria is really common, like Equatorial Africa, then you are much more likely to survive over evolutionary time and pass that gene on than someone who doesn't have those genes and may succumb to malaria. On the other hand, because if you have 2 copies of that gene, you get sickle cell disease where all of your hemoglobin's affected, and this is a very severe condition because the hemoglobin forms very fibrous deposits inside the cells, bending the cells and making them jam in blood vessels. It's very painful, and it causes all kinds of end organ damage over time. Those people would have a real problem over evolutionary time, and the evolution would normally remove that condition from a population. And it's called a balanced polymorphism because malaria makes it advantageous to have a disease. And so nature tolerates people who are affected to some extent but not badly affected because it confers protection against a disease that's worse, and that's malaria. So you tend to see that selective pressure where malaria is common, and hence before people started being quite so mobile around the planet, most of the cases were cropping up where the disease that's keeping that gene in circulation is most common, and that meant equatorial regions and particularly Equatorial Africa.
Cape Talk.
We've got Linda on the line. Linda, go ahead for the Naked Scientist.
Hi, good morning. Yes, I'd like to find out, my son is flying over from the United States of America next week, and he has got a pinched nerve between C5 and C6. What can he do to help alleviate? He says the pain is excruciating, and I thought, he says he doesn't know, it's a long flight. What can he possibly do to ease the pain, and how long will it take to heal?
Hi, Linda. Sorry to hear about your son, but you'll be pleased to see him, I'm sure. This is very common. What Linda's referring to with a pinched nerve is that all the way down our spinal column, which is the series of bones at the top of the cervical vertebrae, C's, the thoracic vertebrae, T's, and the lumbar vertebrae, L's, this sequence of bones are all articulated, one balanced on top of another. And there's a hole down the middle of those bones, which is the spinal canal. And the spinal cord, which connects at the bottom to nerves down your legs, and at the top to your brain stem, which links it up to your brain, all the way down the spinal cord, there are nerve roots coming off at the front and at the back that then flow out from between the bones to then make spinal nerves that then go into all your tissues. And up at the neck level, you have a massive band of these nerves called the brachial plexus, which comes out and supplies your upper limb. Now, because each of these bones is delicately articulated, one on top of the other, stabilized by ligaments and muscles, and has to be able to move all over the place, and you think about the movements we make with our head, our neck takes an enormous amount of punishment. As we get older, several things happen. The discs, which are the spongy materials that separate each of the bones, become thinner and sink a bit. And also the bones themselves, which have little joints between each of the bones called facet joints, they wear, and you can begin to deposit or build new bone at the margins of those joints. These are called osteophytes. And because new bone has to go somewhere, it takes up space. Where does it go? Well, it can go into the bit of the bone where the hole is that the nerve comes out of. So it begins to impinge or squeeze on these nerve roots that come out and go into the spinal cord. And as a result, you feel neurology or experience pain, or you have weakness in the part of the body that nerve supplies. So the first thing whenever anyone gets mechanical neck or back pain is to say to them, about a third of the time, this is not going to get any better. About a third of the time, it's going to get better on its own. And about a third of the time, you might need someone to do something about this. They need to start with some simple analgesic remedies. So take painkillers to start with, because it might be a temporary thing. It might just be a muscle strain, which means that the bones are a bit unstable and that's squeezing on the nerve. If it's a chronic problem, it needs investigating. The appropriate investigations include imaging. So we do the right sorts of medical imaging like X-rays and CT scans to get a good picture of what the bones all look like. And this may point to where the problem is. And either a neurosurgeon or an orthopedic surgeon might decide that it's necessary to operate, or they might find other ways to help give some relief and stabilise whatever is unstable and causing the impingement on the nerve. So it needs proper investigation, and if it's a chronic thing, it's probably not going to get better on its own. And if it can't be managed with simple remedies, escalating it for a bit of investigation and possible further intervention is going to be the way to deal with it.
Let's take that voice note from Jason.
Hi, Clarence and Dr. Smith. It's Jason here. Quick one. When the guys dive and they come up too quickly, they get that decompression sickness or whatever it's called, or the bends. What actually happens there? And why do they call it the bends?
Jason, the reason for this is when we go underwater, because water is much denser than air, the weight of water above you when you go a relatively short distance down is enormous. In fact, for every 10 metres that you go down in the sea, the pressure grows as though you've got a whole atmosphere of 100 kilometres of air above you. So if you want to inflate your lungs with air 10 metres underwater, you've actually got to supply pressure to your lungs to inflate them by the same amount that's twice as much as it would be at the surface. If you go down 20 metres, it's now you need pressure 3 times as much, and so on. So as we go down deeper underwater, you are breathing air which is much denser, because if you put the gas under pressure to push it into your lungs, the density goes up, and the actual number of molecules you're breathing goes up. Now, what this has the effect of doing is forcing into solution, in other words, to dissolve in your blood, a gas that makes up 4/5 of the air around us, but which doesn't like dissolving very much, and that's nitrogen. Nitrogen is an inert gas. The body doesn't use it. It comes in with every breath, and most of it goes out again, but a small amount dissolves in blood. But if you increase the pressure of the nitrogen, and this happens with any blood, any gas, it's how we dissolve carbon dioxide in a fizzy drink, for example, you will force more of the gas to dissolve. So a diver working underwater for any period of time is forcing more nitrogen to dissolve in their blood than normal. Now, you can imagine if you reverse the process and you surface, as you come up, the pressure on the body, on the blood, and in the lungs is dropping. The nitrogen says, well, hey, I don't have to be dissolved anymore. Now, if you come up slowly the nitrogen moves out of the blood and back into your lungs and is breathed out harmlessly. If you don't come up slowly, but instead surface very quickly. You take the pressure off very quickly. And as you know, if you take a bottle of fizzy drink and you open the lid too quick, you see all the bubbles appear all at once and it goes whoosh. In all your tissues, that's what happens. The nitrogen doesn't want to stay dissolved anymore. It bubbles out of solution and you form bubbles of gas in your blood vessels. And those bubbles can be bigger than the blood vessel, and it completely blocks the blood vessel. And as a result of that, you get deathly pain in downstream tissues. It happens in bones. It can happen in your nervous system. Very, very painful, very disabling and life-threatening. And they call it the bends because when people got this, they would bend over. It would be so excruciating, they wouldn't be able to stand up straight. And it's very, very dangerous. It's a medical emergency. And the best treatment is to put people back underwater effectively, because you put them in a decompression chamber and pump the pressure back up to a very high level, driving the nitrogen back into solution in the blood, and then the problem goes away. And then you slowly decompress the person in the aftermath and warn them not to do it again.
We got to wrap it there. Consultant virologist at Addenbrooke's Hospital in Cambridge, Dr. Chris Smith, also known as the Naked Scientist, every Friday just after 9:30. Hours to enjoy.
You are with Cape Talk.
Views and news with Clarence Ford.